What is the first investigation? The missed IUD, doctor, first thing? X-ray pelvis can give you a wonderful identification of it. What are all? Yes? Yes. Why not ultrasound? Because X-ray pelvis is, I think, more commonly available. What is your possible answer? Is it studied that it is radio opaque and will it appear? Yes? Between ultrasound and X-ray pelvis, and for me it appears reasonably X-ray pelvis. So, yeah, why ultrasound? Okay. You have any valid reason? Any ultrasonic appearance of IUCD missing? Okay, is there any perforation can be identified? Acha. If you can get a literature support, just let me know. Okay, let's go to the next question. What are all the criteria for the low forceps delivery, doctor? First thing you have to see to that is the head is engaged. That is the first thing. In fact, before you do the low forceps delivery, if the position of the head is still abdominal, that is the contraindication for doing the low forceps. So there is a reason for the low forceps criteria is head at zero station. Is it a criteria? What do you mean by engaged? Engaged is it? Right. So head must be engaged is one of the important rules that need to be remembered. What is the most common cause of hirsutism, doctor? Polycystic ovarian disease. At vaginal examination, second stage labor, anterofontanal supraorbital ridge is found. Then what is the presentation? Bro. One of the presentations will invariably come. Anencephaly is more common in the case of face presentation. So anencephaly means there is no head. How can face there be? All that logic should not work in in the exam. You need to answer few things at spinal level. No logic over there. Most common presentation of the gonococcal infection in the females is the acute cervicitis. Pyometry is best treated by what, doctor? Dilatation, curettage and antibiotics. Only blind antibiotics will not help. Chemotherapy for dysgerminoma, what are the various regimes available? VAC regime, MAC regime, BBP regime, BEP regime, all these things. So there is a reason the answer would be cyclophosphamide, vincristine and actinomycin D along with the prednisolone is considered to be the best regime. Sterilization with least failure is Pomeroy. What is the percentage, doctor? 0.4%. So one question on contraception, without that there is no paper. It is, yes? Yeah. Put forward your possible answer. Is it? Is it Irving's method? What is the percentage? 0.01? Good reference. So 0.01 comparatively. So this is 0.4% because the recanalization, there's a small correction. 25-year-old lady who has got one child, who has got a uterovaginal prolapse and who want to have another child and maintenance of fertility is what she is desiring, then what kind of surgery do you want to do, doctor? Uteropexy is considered to be the treatment of choice. So please remember, what's the most common symptom of the uterine prolapse is my question to all of you. Typically a feeling of the pressure or something is protruding from the vagina is the most common symptom in the case of the prolapse. And often the patient says that I am feeling that as such I am sitting on an egg, or sometimes they can give a dragging sensation or a backache. They all can be the classical features. And this feeling typically is relieved by lying down and it is less noticeable in the morning. Typically it will be worsening as the day progresses. So these are all the very classical features of the prolapse. Let us talk about uteropexy. Typically when uterine prolapse occurs in a young nulliparous patient who wants to retain her fertility, it can be managed by a pessary. And the older abdominal suspension operations like Gilliam, ventral suspension, hysteropexy do not work for the patients who have got the uterine prolapse is what need to be remembered. And how about the Manchester operation, doctor? What do you do in that exactly? The bladder is dissected off the cervix, which is then amputated, and the carnal ligaments of the anterior cervical stump and the posterior vagina are closed over the rest of the opening. and basically the opening is usually performed in conjunction along with a colporrhaphy procedure, and in this those women who are not desirous for the fertility, in them you can carry on this procedure is what need to be remembered. Let's go to the next question. Most common cyst in the anterolateral vagina would be Bartholin cyst. Very good. So Wolffian duct is basically imperfect duct. It runs parallel to and below the fallopian tube in the mesosalpinx is what need to be basically remembered. So the duct passes downwards by the side of the uterus at the level of the internal os. It runs forwards and finally opens anterolateral in the vaginal wall, and it will reach sometimes down up to the level of the hymen, and it forms a cyst which is called the Gartner's cyst, which can be located in the vagina or in the broad ligament. And what is the management of this Gartner's duct cyst, doctor? Enucleation is considered to be the treatment of choice. Let's go to the next question. From the Wolffian duct remnant, what is growing, doctor? Gartner's cyst or Wolffian cyst? Gartner's cyst. So don't worry that in the same exam 2 questions on the same topic can come. So that's the reason just because it came you need not answer something else for the next question. So 3-4 questions also can come on the same granuloma inguinale. Because examiner doesn't want you to strain much if many questions are given. Same topic, same question repeated 2-3 times means easy after coming out of exam hall to write the paper. Probably that is the reason. Let's go to the next question. Cyclical hematuria, where do you come across? One is in endometriosis, you can find it. Second is in the case of a uterovesical fistula, which is a common consequence of the caesarean section. In that case also, uterovesical fistula, cyclical hematuria can occur, because whatever that is shed endometrium will be passing through the bladder into the urine cyclically, hence cyclical hematuria can occur is what I want to underscore. Then Klinefelter syndrome typically will be associated with hyalinization of the seminiferous tubules in the testis. So when the end organ got disturbed, there is nobody to inhibit the FSH in the pituitary. Hence FSH levels of the pituitary become elevated but not depressed. So how do you differentiate whether the hypogonadism is because of the problem in the gonads or in the pituitary? In the hypogonadic hypogonadism, in that situation high amount of gonadotropic hormones will be there. Whereas if it is because of pituitary problem, low levels of the FSH will be there. That's how you will be able to differentiate between the two. Transplacental toxoplasmosis transmission occurs in the 3rd trimester. And placental site trophoblastic tumor, PSTT. What is true about it, doctor? Do you think placental site trophoblastic tumor, can you use chemotherapy alone, or do you want to do resection? Alone chemotherapy is, chemotherapy, is it useful? That is one thing that rules out. Hysterectomy is used. And let's go to the next question. Billings method of contraception typically depends upon what, doctor? Cervical mucus. Single umbilical artery is associated with IUGR, congenital abnormalities. Yeah, it can be a benign finding where it may not be associated with the major congenital abnormalities. Is it like that? Yeah, here some small repairs need to be done, because these are all questions based on the memory, right? All the following are true about postpartum hemorrhage. Can you use mifepristone here, doctor? You can use misoprostol, methergine, carboprose, but not mifepristone. Renal agenesis is seen typically associated with oligohydramnios.